Thank you for inviting me to this important conference. First, I would like to express my gratitude to all the organizers. We have no financial conflict of interest regarding this presentation. I'm honored to be here today to present on behalf of Kyoto Daiichi Redcross Hospital. Let's take a moment to introduce our hospital. Kyoto Daiichi Redcross Hospital is located in Kyoto City. Kyoto City is one of the most popular cities for foreign tourists visiting Japan. Our institution is located near Tofukuchi Temple and Kiyomizu Temple. Both sites are popular temples in Kyoto. In recent years, the number of travelers has been increasing, making our hospital important for travelers too. In summary, our hospital provides excellent healthcare in the center of Kyoto. So moving on to our next point, today I will present the topic of Needle Tract Seeding (NTS). NTS can happen as a complication when doing USFNA for early pancreatic cancer. First, I will provide a general overview of USFNA in the context of pancreatic cancer. Then, I will present case of NTS we have encountered at our institution. Finally, I will discuss the strategy and response to NTS based on our clinical experience. Despite the advancement in diagnostic technique in pancreatic cancer, early diagnosis remains difficult, and its prognosis is still poor. Here, I will show the trend in cancer mortality rate in Japan. It's currently the fourth leading cause of death, and an increasing trend is expected in the future. On the other hand, for pancreatic cancer diagnosed at the early stage, particularly with a tumor size of 10 mm or less, a good prognosis can be expected. This is the survival rate at 5 and 10 years after resection for stage 0 and stage 1 in Japan. Therefore, it is important to detect pancreatic cancer at early stage. There is also the viewpoint that surgery without a pathological diagnosis might be considered. However, thinking neoadjuvant chemotherapy, a pathological diagnosis before surgery is often necessary. EUS-FNA is becoming the standard method for pathological diagnosis. However, it is true that there are still challenges with using EUS-FNA for small pancreatic cancer. I will present a table summarizing the diagnostic accuracy of EUS-FNA from multi-center and single-center study in Japan. According to our report, EUS-FNA is relatively reliable for tumor 10 mm or larger. However, the diagnostic capability for tumor 10 mm or smaller is not yet perfect. As mentioned later, the goal is collect a sufficient specimen with a minimum number of punctures. I will show the figure of complication from EUS-FNA in a multi-center study conducted in Japan. The overall probability of complication, both major and minor, is 1.7%. This number is relatively low, suggesting that EUS-FNA can be performed safely. Even though it is rare, needle tract seeding is a serious complication that can't be ignored. Today, NTS is the main topic of this presentation. Needle tract seeding occurs in the stomach after EUS-FNA. Additionally, they often had resectable pancreatic body and tail cancers because the surgery does not remove the punctured stomach. Currently, the importance of pathological tissue is increasing. This is also due to the growing popularity of neoadjuvant chemotherapy. Consequently, the risk of NTS may become increasingly sufficient. The impact of prognosis is not clearly understood, but US FNA for diagnosis of resectable pancreatic body and tail cancer present a clinical dilemma. We need the benefit and risk must be carefully weighted on a case by case. Next, I will present case of NTS we have experienced at our institution. Following that, I will discuss methods to reduce the incidence of NTS as much as possible, and summarize the current report on this topic for further analysis. An 83-year-old male underwent a follow-up CT scan after sigmoid colon cancer treatment. An area of poor enhancement in the body of pancreas and dilation of the main pancreatic duct toward the tail were observed. I will show the CT image. A hypoenhanced area was observed in the pancreatic body, and the main pancreatic duct on the tail side was dilated. No enlarged lymph nodes were observed in the abdominal cavity. For diagnosis, USFNB was performed. An irregular low echo tumor located and interrupted the main pancreatic duct. I punctured 3 times from the stomach and got some tissue. The pathological result confirmed adenocarcinoma. Since no lymph node and other organ have no metastasis, surgical indication was considered, and distal pancreatectomy was performed. Post-operative pathological diagnosis confirmed pancreatic cancer stage 2A. After undergoing neoadjuvant chemotherapy for 6 months post-surgery, the patient was followed up on an outpatient basis for 3 years. He had no sign of recurrence. However, 37 months after FNA, an elevation in CA19-9 level was observed. I have graphed the temporal change in CA19-9 level following FNA. At the 37 months, we found a elevation of CA19-9, so a PET-CT was performed. This is PET-CT at that time. We found no abnormal accumulation. As CA19-9 level continued to rise, upper endoscopic tests were conducted at 41 months. We observed an erosive region on the posterior wall side of gastric angle. A biopsy was performed, but no sign of recurrence were found. A contrast-enhanced CT was performed at the 45 months past FNA, but no abnormality was noted. At that time, a PET-CT was examined. Abnormal accumulation was observed on the posterior wall of gastric angle. Consequently, I do endoscopic examination again. An ulcerative region with a raised edge was found at the previous biopsy site, and EUS was performed at that time. A 25 row echo tumor was identified outside the gastric wall. Another biopsy was done, and this time it was diagnosed as adenocarcinoma. Since it was near the puncture site of the FNA, gastric wall metastasis of pancreatic cancer, also known as a needle tract seeding, was suspected. Compared to the endoscopic finding from 4 months ago, it was found an ulcer had formed at the same location where mucosal erosion was previously observed. Since there was no metastasis to other site, a distal gastrectomy was performed to achieve local resection. This is a post-operative specimen. MUC1 and MIB1 are positive. Based on this result, NTS was diagnosed. Two months after surgery, a PET-CT scan indicated abnormal accumulation. We suspected pediatric dissemination. Despite chemotherapy, the patient developed multiple pediatric dissemination and died 55 months post-FNA. Based on our report and reported case, I'll present characteristics of NTS and our institution's approach to manage it. Today, I will highlight 3 key points for managing NTS. First, I will discuss our effort to minimize the risk of NTS as much as possible. Here, I present a figure from a report that analyzed 25 case report of NTS. The analysis provides valuable insight into the incidence risk factor and outcome associated with needle tract seeding in this case. Summarizing the result and comparing them with own case, we found our case is generally average. The 22-gauge needle was the most frequently used, and we might say the F&B needle gets a lower risk. The time to recurrence detection in our case was 45 months, which is longer than the average. However, recurrence period is wide-ranging. I suggest we need for long-term follow-up. Based on this result, we present the precaution in performing punctures. Regarding needle section, we believe the use of F&B needle is useful to obtain sample with fewer punctures. This is a comparison of the sample volume obtained with different puncture needle. On the left, the sample volume from a 25-gauge needle, and on the far right is from a 19-gauge F&B needle. The Francis needle collects more sample volume compared to the Lancet needle. At our institution, to ensure sufficient sample volume, we use the Francis needle or fork-tip needle. In addition, I introduced in vitro study. This report examines the risk of tract seeding with the use of side hole needles. The model was punctured using agar and two kinds of needles, one with side hole and one without. They stroke and check the leakage of crystal violet into the top layer. It was observed that when using the side hole needle with the stroke pull technique, leakage often occurs during the stroke. The leakage of tumor cell from the side hole and attachment of tumor cell are considered directly cause of NTS. It is important to avoid contact between the punctured tumor cell and normal tissue. Therefore, at our institution, we wipe the needle with alcohol swab after each puncture and avoid using side hole needles in case with a high risk of NTS. The importance of rapid on-site evaluation has been highlighted in the past. Past report indicated that there was no significant difference in diagnostic rate when using F&B needle whether loss was performed or not. There is precaution to be taken during F&A punctures. Next, I will discuss strategy for the early detection of NTS. It is difficult to eliminate the risk of NTS completely, so early detection is considered as important as reducing the risk, I think. When following up on NTS, common modality includes tumor marker, CT scan, PET-CT scan, and endoscopy. The advantage and disadvantage of each are as mentioned here. Particularly, like our case, when tumor markers are elevated but recurrence is not clearly indicated on CT scan, we suggest endoscopy may be useful of early detection of NTS. However, endoscopy is not perfect. In an evaluation of 22 out of 26 previously reported cases with documented endoscopic findings, 17 cases were reported as submucosal tumors. But there are also instances of non-specific erosion or thickening of the stomach wall. When the tumor does not grow into the stomach, the elevation might be significant. The biopsy results can be negative, leading to diagnosis confusion. Additionally, as in our case, the region appears as erosion or looks like gastric cancer. Therefore, endoscopic appearance of NTS may vary widely. While that's important, one of the characteristics of NTS is its origin. It is at puncture site. Therefore, it is important to observe the angular part and puncture site and compare it with the image taken during the puncture. If no elevation is observed, EUS should be aided. On average, the duration from FNA to recurrence detection is 20 months. However, this can vary significantly from a few days to several years. Therefore, long-term follow-up is considered necessary. At our institution, we perform endoscopic examination annually. These are the points to detect NTS. Last is to select approach treatment method. Based on this report, collected 46 cases of NTS. There are two perspectives on NTS. It can be considered either as a metastasis or as a de novo region. In practice, the latter perspective is more commonly adopted. However, detailed report on the surgical method and prognosis are lacking. Further accumulation of cases is anticipated. This is conclusion of our approach to manage NTS at our institution. In any case, because NTS is a rare condition, there are currently limited conclusions. Therefore, case report and data accumulation are eagerly awaited. In summary, the diagnosis of early pancreatic cancer using EUS-FNA is expected to rise and become more important in the future. At the same time, the importance of managing NTS is also expected to grow. Thank you for your attention.